So I'm going to talk about renal functional reserve before and after AKI. I have no conflicts to disclose, and I would like to start, like I always do when I talk about AKI, with the critical guidelines. I mean, we all know that the development of AKI depends on the intensity of the insult and susceptibility of the kidney, and that is what the critical guidelines say, that we have to recognize patient subsets that are at high risk, but that can be really challenging, especially when we don't have patients who have underlying chronic kidney disease. In fact, one of the main determinants for the individual susceptibility of the kidney is, on the one hand, whether the patient has comorbidities, but also the number of intact nephrons that essentially relate to the functional capacity of the kidney. However, as you can see, up to the time of birth, the number of nephrons can vary significantly, which is probably one of the main reasons why some patients are more prone to develop chronic kidney disease, and that is a low nephron endowment at birth. And you see that you have a significant nephron loss occurring physiologically with normal aging. So there is a dynamic within the kidney that we may or may not always realize. And to get an idea of that, colleagues of the Mayo Clinic, they looked at living kidney donors who had a pre-donation CT scan and a protocol biopsy of the donated kidney during transplant surgery. And in those biopsies, they analyzed thoroughly how many glomeruli are intact and how many are sclerotic. And with that information, the number or the density of the glomeruli and the cortical volume measured in the CT scan, they estimated the total number of nephrons throughout the age. So as you can see, the number of the intact nephrons, so this would be the white bar, decreases with age, and at the same time you have an increase of the sclerotic glomeruli. But when you add both the intact and the sclerotic glomeruli, there remains a gap. So the sclerotic glomeruli, they don't fill the gap, and that can only mean that you have a subsequent loss of nephrons. And when you look at it in terms of quantity, you see that at the age of 70, almost 50% of intact nephrons are gone, and those are patients that that are accepted as living kidney donors. But the reason why I'm showing this, another one, so when you look at the GFR, so that would be the red line, it decreases with age, but after the age of 60, the GFR decreases to a lower extent than the number of intact nephrons, and that can only mean that the individual glomeruli, they have to work more. Compensation, hyperfiltration. So we have a significant age-dependent change of nephron number, but not every change leads to an increase of serum creatinine. Well, and this leads us to the next question: how good are we to measure renal function, particularly functional renal mass? And the answer is bad, and you all know that. All we have to do is look at a normal human being and measure GFR in the same person who is on vegetarian diet and high protein diet, and all of a sudden the GFR can double or even triple in those patients. Although, or even because, or yes, the renal functional mass is exactly the same in the same patient. So a static measurement doesn't necessarily help us here. What we need is a dynamic measurement. Similar like when the cardiologists, they do a cardiac stress test, we need a renal stress test in our office. And that leads us to the concept of renal functional reserve. And the big question is a glomerular in a particular situation at its limit, or is still capable to increase the GFR? So one can form the hypothesis that glomeruli working at the limit, they have a worse prognosis for AKI compared to glomeruli still have the capacity to regulate the GFR up and down. So the assessment of renal functional reserve, which is the capacity of the kidney to increase the GFR in response to stress, can help us here to better discriminate among patients who have the same baseline GFR but have an increased risk for AKI compared to those who have an intact renal functional reserve and a better long-term prognosis. And only after the renal reserve is lost, ideally, AKI will be diagnosed according to KDIGO criteria, and before that, all insults may stay subclinical, leading to a significant damage without, however, affecting baseline GFR. And to prove the concept that subclinical AKI has clinical impact, it was actually shown some couple years ago that patients having a positivity of biomarkers, however, not having an increase in serum creatinine, they seem to have a similar worse outcome compared to patients who have clinical AKI. So it does make sense to combine new biomarkers with traditional markers of AKI to better prognosticate those patients. And to prove our concept that renal reserve, the assessment of renal functional reserve has prognostic and diagnostic value, we did a pilot study in adult patients with normal baseline GFR undergoing elective cardiac surgery, and we measured renal reserve with high oral protein loading. And the reason why we chose cardiac surgery is pretty easy, because AKI is quite common here, and the timing of injury is known, which is the surgery. So this was the study design. We measured renal reserve 1 day before the surgery with high oral protein load, and immediately after the surgery, we studied creatinine, urinary output, and biomarkers to analyze how many patients have AKI and how many patients have subclinical AKI. And to get an idea of renal recovery, we repeated the kidney stress test 3 months after the surgery to look how much is left of the whole functioning renal mass. And as biomarkers, we chose TIM2-RGPP7 since those are currently one of the most promising. They seem to be more sensitive to kidney injury than creatinine, and we defined subclinical AKI as biomarker levels above 0.3 without positive KDIGO criteria. And by doing this, you see the endpoints. We hope to clarify a little bit what is the nature of an AKI event, both clinical and subclinical, and also the events occurring after AKI, including repair and maladaptive repair. And by analyzing renal reserve at 3 months, we would analyze how many patients would have lost some of their renal function, which is, however, clinically non-evident because part of the nephrons are lost, but still baseline GFR is the same. So here you see first the first part of the results. This has been recently published. So as I told you before, this was a pilot study. We had an AKI incidence of 14%, and among the AKI patients, 10 had stage 1 AKI and 5 had severe AKI, so not so many patients. All patients were diagnosed within 48 hours. Fluid balance adjustment didn't help to change the AKI incidence. All were staged and diagnosed according to KDIGO criteria, and interestingly, almost 40% had subclinical AKI. That means increased biomarkers, but not clinical AKI. And when we looked at the preoperative renal function reserve, it was significantly lower in those patients who subsequently developed AKI after the cardiac surgery compared to those who did not. So 15 ml compared to 27 ml. So remember, those are old patients who had a normal baseline GFR. The baseline GFR was about 80 ml, so totally normal. And when we looked at the preoperative renal function reserve in terms of interval and the risk to develop AKI, we saw a clear trend, meaning the less the renal reserve, the more it is likely that the patient will develop AKI. And using ROC curve, renal reserve predicted patients who would subsequently develop AKI with a C-statistic of 0.83, and a cutoff value of 15 had a good sensitivity and very good specificity. In fact, patients with values less than 15, they had a greater than 10 times increase in risk to develop any type of AKI compared to patients who had values above. So regarding the multivariate analysis, well, the traditional factors like age, sex, body mass index, they predicted AKI quite good, 0.76, but however, the low sensitivity. And when we added the preoperative renal function reserve, the model improved significantly. And when we then finally added intraoperative variables like cardiopulmonary bypass time or the clamp time, the ROC curve improved to 0.95. So the preoperative renal function reserve works pretty well, at least in our pilot study, and it's even better than any other scoring system that we have nowadays in cardiac surgery to predict any AKI. So now to the second part of the results. Now this is not published, it's currently under review. So it turns out that among patients who developed AKI, so these are patients who had stage 2-3 AKI, those are patients who had stage 1 AKI, they all lost some of their renal function reserve 3 months after cardiac surgery. So it appeared that all of those patients, they had a normal renal function. So all of those patients had a normal baseline GFR 3 months after cardiac surgery. Yet they had a defect when we provoked it with a kidney stress test. And interestingly, patients who did not develop AKI but also had increased biomarkers, they also had similar decreases of renal reserve 3 months after cardiac surgery. Whereas patients who did not develop AKI and did not have increased biomarkers, they have intact renal function reserve. So it may well be the case that we think everything is fine, the patient has recovered, baseline GFR is normal, but still it is possible that the patient might have lost some significant amount of renal function. And the only way we can see that is by repeating the kidney stress test. And when we looked at changes of renal reserve, according to biomarker levels, independent whether they developed AKI or not, so it's just another way of looking at it, the greatest decrease of renal reserve we had in those patients who were biomarker positive. And yes, among different time curves, the ROC curve for biomarkers, increased biomarkers 30 minutes after initiation of cardiopulmonary bypass, so pretty early, was this most significant to identify patients who will develop a decrease of renal reserve 3 months after cardiac surgery. So the impact of this study, first of all, is that it was not the baseline GFR, but the lack of renal function reserve that predicted AKI before the surgery in those patients who will develop it after the surgery. And it also implies that the concept of chronic kidney disease starts well before we can even appreciate with baseline GFR. So this is a test that we could do in the patients, in our office, before they go to a surgery. And obviously it has to be something predictable, timely predictable injury, or we can just do it just to look at the evolution of renal function. And at the same time, it may play a role to assess renal recovery after any type of AKI, and that includes subclinical AKI. I mean, nowadays we just have creatinine to assess renal recovery only. And it might help us to distinguish patients who have a full recovery, who have a normal baseline GFR and intact renal reserve, from those who have an apparently full recovery, which would be where we think everything is fine, but the renal reserve is now reduced, and from those who have a non-recovery, and those would be the patients who have an overt chronic kidney disease, where the renal reserve is lost. So the study had several limitations. It was single-center design. We had a low AKI rate, which was actually not surprising because we excluded patients with chronic kidney disease, which is the most strongest risk factor for AKI. Also, we selected patients low comorbidity status, elective surgical procedure, and so on, all factors which are associated with low AKI. And we identified a cutoff 15 to predict AKI in cardiac surgery patients, but of course this needs to be demonstrated in larger cohorts, more heterogeneous population. And well, probably the main reason why the renal reserve is not has not been studied so extensively in the nephrology community is that its measurement is cumbersome. It takes about 7 hours. And yes, creatinine clearance, which we use to measure renal reserve, may overestimate GFR. So to come to a conclusion, patients undergoing elective cardiac surgery, preoperative renal reserve was highly predictive of postoperative AKI. At 3 months, AKI, but also subclinical AKI, was associated with significant decrease in renal reserve. However, none of the patients had a change in their baseline GFR. And just to give it an outlook, we are currently conducting a multi-center study to validate our findings, and here we will use different measures of GFR to estimate renal reserve, what is the tubular reserve, what is the glomerular reserve, and that will include UXOL. Thank you for your attention.